Hi, my name's JQ. I'm going to be performing my heart, peripheral, thorax, and lungs assessment. Going to circle the room to show that there's no nephews. Shelf. Oop, hold it up. There's some notes on here. Okay, I'm going to check my chart, wash my hands, and provide for privacy. And then I'm going to get two patient identifiers. Can you confirm your name and date of birth for me, please?
Peripheral, Washington, January 16th, 1990.
Thank you. And we're going to be performing a lung, thorax, and um, heart peripheral assessment on you. Okay.
Okay.
I'm going to start with let's ask you a few questions. I want to get some background on you. Do you ever have any chest pain or heart issues?
No.
What about any breathing problems, asthma, shortness of breath, anything like that? Do you have a family history of breathing issues, any asthma,
No.
shortness of breath in your family?
No.
And what about any family histories of any heart, cardiovascular, hypertension, or high cholesterol in your family?
No.
Okay. So, just gonna go start by assessing what I see so far, and from what I can see, you're not in respiratory distress. You're not using any accessory muscles to breathe, so that's a good thing. And based on your skin, it's appropriate for your ethnicity, and there's no pallor or cyanosis or anything, and the hair on your skin is distributed evenly and accordingly for your gender as well. Also, if he was a female, I'll ask about regular breast examinations, but also men could get breast cancer as well. So, have you noticed any irregular masses or in your chest area at all?
No.
Okay, well, that's good. And if you do, that would be a significant sign to see your doctor. And a woman, it would be also a significant sign to visit her doctor. Okay, so I'm going to start with checking your carotid artery, which is located here in your neck. We want to palpate it, feel it for any thrills. And then we're also going to auscultate it, listening to any sounds. Okay, so I'm going to touch. There's no thrills. Also, if you could turn your head to the side where you're laying flat, looking for the jugular vein distension. There's no distended vein. I will have him sit up at a 45-degree angle since this one is not movable. When I ask my patient just lift his body up some. If there was jugular distension, will go away with the head lifting up, but he doesn't have that, so that's good. So I'm going to start with some heart sounds. I'm going to ask you to lift your shirt up for me, sir. Okay, so um, what I'm going to do first, I'm going to listen to your heart sounds in the order called ape to man. In your right um, sternal border is going to be your aortic sound, and bilaterally your left sternal border, both in the second intercostal space. The second on the left side is going to be pulmonary, and then the third intercostal space is going to be earth plank, and going down to the fifth intercostal space is going to be the mitral, the tricuspid in the mitral. So it's going to be the H man. So I'm going to listen to your heart doing that. So I'm going to start at the sternal notch. or the angle of Louis, and I'm going to slide over to the second intercostal space. I'm going to listen to your aortic sound. I hear S1 and S2. They are regular. I'm going to go over bilaterally and listen to the pulmonary sound. I can hear S1 and S2 clear, and they're regular. Go down to Herb's point. Also hear S1 and S2. Third, fourth, fifth. Right at the sternal border for the left side, fifth intercostal space, I'm going to listen to the tricuspid. And then mid-clavicular, fifth intercostal space, I'm going to listen to the mitral. I can hear the S1 and S2 clear in all spaces. I ask my patient to turn onto, can you comfortably turn onto your left side? I want to listen to your point of maximum impulse. What?
Yes, sir.
This turn on your left hand side. No, but I need your shirt up. And here, I'm feeling for the PMI of my patient. And I can feel a slight kick. And that's going to be the epical pulse as well. There's the epical pulse as well as my PMI. And while I'm listening here, I'm going to feel his carotid arteries and see if the sound matches with the pulse. And it does. Thank you. Okay, we'll turn back on your back. Okay, now I'm going to be listening to my patient's anterior lung sounds. Noting that the apex of the lungs is supraclavicular, meaning right above the clavicle, I can find the apex of the lung. And noting that following the mid-clavicular notch, the sternal notch, I could go all the way to T6 of the ribs anteriorly and swing it around to 8. So I'm going to actually percuss first in this space for the apex. Both sounds were resonant. Well, listen, take a deep breath for me, please. Thank you. Take a deep breath. In this area, I'm listening to bronchial sounds, which are the highest pitch of the 3 breath sounds, and I'm making sure I don't hear any adventitious sounds, any stridor, wheezing, rhonchi, anything like that. So I'm going to come down, take a deep breath. Take a deep breath. In the mid-sternum area, I'm listening to the bronchial vesicular sounds, which are moderate sounds. Take a deep breath. As I move down further, I'm listening to, the vehicular sounds. I'm sorry. Take a deep breath. Which are the lowest pitched. Take a deep breath. Take a deep breath. Okay, before I move posteriorly, you're just going to get your pulses. I'm going to check your radial pulse, which is strong. It's regular. I would rate this a +3 because it's really strong. Now check your brachial. This one's actually +2. It's not as strong as the one in your radio, but it's still regular. And I will do that bilaterally. And then I'll have my patient lift his leg up, just bend it, and I'll cup, and I'll try to find the popliteal. The popliteal is actually the hardest one to find, but his is actually kind of strong in here, and if you feel deep into through his meat, it's probably rated about a +1 in comparison to the radial and brachial pulses, but it's still regular. It's a little diminished. Then I will come here to his dorsal pedis and get his pulse on the foot. Found it right here. As soon as I touched it, I'll rate that a +2, regular, strong. And I cup around and find the tibial pulse, which is actually strong as well, regular and normal, +2. And also the femoral, which is also regular. Okay, and I'll get your cap refill, mostly on the inner 3 fingers. Less than 3 seconds. Less than 3 seconds. Less than 3 seconds. On the cap refill on the fingers are less than 3 seconds, which is a good finding. Normal finding, I'm going to do the inner 3 toes. Which is also less than 3 seconds. Then I'll have my patient sit up. And from here, I'm going to check his AP diameter by using my measuring with my hand. Come around, trying to keep my hands equal and lateral. And I'm looking for 1:2 ratio, which he does have. So his AP diameter is 1:2, which is a normal finding. And then I'm going to check his expansion. I'm going to come down to T10. I'm going to start by his using his spinous process, which is the C7, and then marking that it goes down to T3 before, with the T4 actually, when it's adjacent with the ribs. If you could hug yourself some, so I could try to find the end of your scapula. Can you move your arm out so this one just, lift it up. Okay. That's the end of the scapula, which is going to be T8. I go down to T9, T10. I know this is T10, 11, and 12, which is going to mark the end of his lungs on a deep inspiration, but normally at T10. So I'm going to put my fingers at T10, pinching them together. Can you angle this a little bit? Pinching them together. Pinching them together. I need you to take a slow, deep breath in and out your mouth. And my hands move equally and bilaterally on each side, which is a normal finding for equal chest expansion in the back. Then I'm inspecting his skin. There's no cyanosis, no kyphosis or scoliosis in the midline, no deviation of the spine. The skin is warm to touch. There's just a few scars on here with nothing that deviates, and that's abnormal. No abnormal bruising, no abnormal masses or anything. So then I'm going to percuss following those landmarks that I gave. And I'm going to do that bilaterally, listening for resonant sounds. Noting any dullness, which could represent abnormal finding. So all the sounds were resonant. And now I'm going to check for crepitus, which actually I should do when I expected. There's no crepitus. There was no crepitus in the front. Crepitus is almost like a Rice Krispie look to the skin, which is air bubbles into coming out of the skin. Now I'm going to have you say 99.
99.
99.
99.
99.
99.
99.
99.
Okay, this is a normal finding. It was more resonant at the top, diminishing at the bottom. So his tactile formatus is normal. And now I'm going to listen to his breath sounds. I'm going to start at the apex of the lungs. If you could take a deep breath for me. And take a deep breath. Take a deep breath. Take a deep breath. Making sure that I stay in the midline area, not on the vertebrae or not on the scapula, right in the middle, right up in this area, the T1, T4. I'm listening to the bronchiovesicular sounds, and then going as I go down along this line, noting that these are my vesicular sounds, which are my lower pitch, and these are my moderate, and only in the front neck can I hear the bronchial sounds. Okay, I'm at T1, 2, 4, 5. Take a deep breath. Take a deep breath. Take a deep breath. Take a deep breath. Now I'm getting to T8. Take a deep breath. Take a deep breath. And I'm coming to the lower lobes of the posterior chest. Take a deep breath. Take a deep breath. Then I'm going to come around from T10 over to T8 laterally. Just going to slide that around. Take a deep breath. And then if I move up 1, 2, I'll listen at T6. Take a deep breath. Okay. Also, I want to note in the anterior chest, the right lobe has 3, and I would have been listening to my mid lobe at around T4 before I got any further to T5, T6, where I'd be listening to my lower lobe of my right lung. Okay. And that concludes my assessment of the heart, lungs, thoracic assessment.